that's not a priest on duty, because this one has a channel on duty. It's really no good, because he's talking about at least he's Greek Orthodox Church. But I don't know if he's from Greek or Russia or where he's come from. But he's really, really fun. Yeah. And so when he says, I guess he would be the one out.
Good morning. Thank you all for joining us for this side event, scheduled in the first slot of this morning, of the third day of the CND. Thank you all for joining us. My name is Milutin Milosevic. I am the Executive Director of the Drug Policy Network Southeast Europe, which is formally host of the event, but it's actually the group of our organizations which are working together in the BOOST project, which has prepared the event, and we will present you some elements of the information about the BOOST project, but also some of the activities we are planning or we would like to do on advocacy, how to use the results and experiences and learning from the project to improve the services delivered for people who use drugs. So with us today we have Katrin Schiffer, Director of Correlation, European Harm Reduction Network, Gana Dobak, Eurasian Harm Reduction Association Director, and also Chair of the European Union Civil Society Forum on Drugs, but it's not her cat for today. Then Lydia Parodi from the European Network of People Who Use Drugs, and Mario Sodzemis, who is here formally representing us, Drug Policy Network Southeast Europe, but there's several cats which he will probably take off and on during this speech.
With no rabbits.
So as we wrote, this side event aims to present and discuss a strategic advocacy framework that advances comprehensive health and harm reduction services for people who use drugs in Europe and beyond. First, I would like to thank all these people organizations which have supported the event. They include the Czech Republic, country of Czech Republic, then Pompidou Group, which is the Council of Europe International Cooperation on Drugs and Addictions. Unite, the Parliamentarians Network for Global Health, Correlation, Eurasian Harm Reduction, European Network of People Who Use Drugs, and then organizations which are participating in the project, Regeneration from Serbia, Villa Mareni, Italy, Barcelona Institute for Global Health, Fondazione Lilla Milano, Italy, Association Bienestar del Desarrollo, Spain, I hope it was okay, probably not. Free Clinic from Belgium, Společnost Podane Ruce from Czech Republic, and Nomad Institute from Germany. So I'll first give the floor to Katrin, who will present briefly the project and introduce us to the whole thing.
Yes.
Please.
Now, I would like to welcome everyone here. Happy that you are here. And when we discussed the whole setup of the workshop, we said, okay, I will speak very shortly, so we have more time for the other speakers, but also hopefully have time for a discussion afterwards. So I just want to give you a very short overview of what the BOOST project is. So it is an EU-funded project by the EU for Health programs, and the main aim is to enhance the implementation of high-quality, community-based and community-led communicable disease service. This is a horrible because communicable disease service and also harm reduction service. So we are really working on the promotion of community-based and community-led services in the field of HIV/AIDS and viral hepatitis prevention, treatment, and care. And we have all kinds of partners. I won't read them, but just for your idea, the ones in black are not official partners because we were not able to involve them at that time, partly because they did not belong in the region where they could, and also, but they are also part of our consortium in a way. Go to the next one. I give you the different areas of work. So we have 4 so-called work packages. The first one is about collecting data and information and on community-based and community-led services. So we have a multi-modular service which was carried out in the first year, which was a monster, we called it, because everyone from the project provided input, and people who filled in the survey were really asked nearly, I would say, because it was really a long survey. And we will now repeat the survey, but in a very shrink form, because the information we asked in the first one is not needed. It is mainly about assessing gaps and service needs. And I share the QR code at the end of my presentation, and I would be really thankful if those who are working in community-based or led services would take the time to fill it in. Then we have our monitoring via the focal points from correlation. So we have a monitoring tool which we implement already since 2019, and we prepare annual monitoring reports. We cooperate with them, and they have adapted as part of the project the COBA to the specific needs of people who use drugs. And we organize focus group discussions with Euro input and the users. So this is the first work package. Then we have a second one which is called Improve. So this is a lot about skills and capacity building. With peer-to-peer webinars, we have a lot of things around digital literacy and developing quality standards, which is currently happening for digital harm reduction services, and also how we can monitor and use digital tools. The third work package would be about the so-called lighthouses or support. So we have identified at the very beginning as partners for good practices around Europe, where we think they have really managed to develop a very good and comprehensive approach, harm reduction approach in their organization. And these four, Villa Marini is one of them, and Kodane Ruce is another one. And there is A Clinica from Finland and
Belgium.
A Clinica from Belgium. No, Free Clinic from Belgium. So these are the four lighthouses, and they have now selected the small mentorships, or with I think each organization is supporting 4 mentorships, services to scale up their services. And they will, the 4 lighthouses provide all kinds of support. And then we have the last work package, which I will not go too much into detail. This is more or less why we are here today. It's about the European Harm Reduction Network and Drug Policy Networks we already mentioned. They work together to develop a joint advocacy strategy. Dana will talk about it. And this is the QR code, which I would like to ask you to make a photo if you wish, and fill it in or share it with your colleagues if you think this could be. It's not a long survey anymore, so it's not a long survey.
So I have a slide presenting Ghana, but let me keep this one until you make a photo with Ghana. Please go on, and you want me to move to your slide? Okay, then there will be a slide again on the end of Ghana's presentation.
So honestly, I don't know how we manage all together all 4 community and harm reduction networks, first of all, to connect together before the storm came. Like, we all know that the harm reduction funding and harm reduction complexity and comprehensiveness is under the threat now, not only because of USAID processes, but in European countries as well. And it seems like a year and a half before this, we already envisaged and planned together the advocacy to, actually we thought to develop, to sustain, but now I would say to maintain what we really have in Europe, and to survive. And it means surviving of our networks as the joint effort of 20+ years effort of coordination, advocacy, learning by our networks. And you see the title, and thank you, Milutin, for putting the titles of the network, and you see that's Eurasia angle, European angle, Southeast Europe angle, and the community, European community of people who use drugs. So that's, if you will imagine the coordinated effort, that's who we are. And from what we started, and you could see a picture from Amsterdam when we actually combined the advocacy strategy together and priorities and advocacy needs together. But before this, we did very comprehensive focus groups with our membership and the people who are doing harm reduction and community who are improving and advocating for harm reduction and for different services. I'm saying harm reduction meaning the services to respond the HIV, hepatitis, and other diseases and tuberculosis, and with the complex of social care and all non-specific for HIV, hepatitis services, let's say mental health. So that's the process, and in the January last year, February, we already came with the strategy. Let's go further, and that's actually, if we see the analysis, first we analyzed the contextual factor impacting the access, and we saw key barriers, and that's stigma. And you could not imagine, I'm from Ukraine, and we could say, okay, Europe is the best place to live. We are all going to European values, and Europe do not have stigma and discrimination because that's human rights values countries. But from this survey, unfortunately, we saw in every question, we saw the answer stigma. Sometimes with discrimination, not obviously in all countries we have the mechanism or community who could work on documenting human rights violations. And that's the only reason why we don't have the real human rights violations documented and went through the strategic litigation. That's why we are saying discrimination. So, and we saw all around Europe a lack of political will, a lot of legislative barriers, from smaller, like no naloxone because that's prescribed drugs, or no community based testing because and I don't know, honestly I don't see the reason why, but just because. And the key point is funding. And I need to say, if we would do this now, not 2 years ago, then the funding will be maybe even first, because we see the signals of the cutting.
I just want to shortly jump into this, because I mean, I think everyone, also funding was on top, or was one of the most important, but we said, okay, let's not always come with funding first, because this is so tiring.
Yeah, not only money deciding, and the political will deciding even more, and prioritization is deciding even more. Let's go further, and then if to speak about the specifically harm reduction interventions, then we have very different regions. In the broader Europe, we have very, very different regions. Somewhere it's really traditional interventions already implemented for 20 years, and there is access, but even with some challenges. But there are some Eastern European countries, I will name here Romania, I will name here Bosnia, Serbia, Hungary, a lot, Bulgaria till recently, who are really do not have harm reduction or have so limited harm reduction funding services organizations. Discrimination, again, funding issue, and the very important issue with the gender-specific challenges, because to develop the services for youth or for women, you need to have peers from these populations, from these groups, and you need specific of the services. And we are lacking it very much, and that's why we need lighthouses to give a light and to show that it's possible and it's not too expensive. Next, then we had specific, not to the symptoms of harm reduction, but to the specific infection disease preventions, treatment and sexual health services, testing on HIV, STI, and hepatitis. And you could see that's very specific barriers, like about the procurement, about insurance barriers for people to come, and specifically migrants, non-documented, documented migrants. It was the research was not concentrating in Ukrainians, but it's not only about Ukrainians, Syrians, for Russians in our countries. Limited specialized services, you could see there, which are needed. Confidentiality concerns, especially with the smaller cities and smaller countries, and policy regulatory barriers, and again migrants, and there are huge barriers about the language and access. And we are coming to the services which we believe should be in the comprehensive package. That's about the access to primary health care, to mental health care, and reproductive health care. Because harm reduction usually is a linkage to this broader health care systems, and they are very needed. And actually what we find out that all of these hierarchies of medical care, they are very, very disconnected. So I do remember when we were trying to connect, to integrate HIV and TB services for people who use drugs, and it means addiction, HIV and TB, and now we need to connect with one more rather strict and rather very low threshold system of the mental health care. And we all know that I could ask you, if you have your psychiatrist telephone, how long you should wait for psychiatrist or psychotherapist to go if it's for free, and even if it's paid. And do you have free mental health, meaning psychology, psychiatrist services at all in your country? If you need, if it's crisis, if it's panic attack, if it's some connected with the new psychoactive substances use, if it's your kid have the panic attack because of used something or not used something, or just watch the movies or watch the news. So that's important story, and the quality of care and connection with the social care. So going to the solutions, actually. It was not easy to decide on the priorities, but actually we decided on the keywords and key priorities, and with the crisis and storm which came afterwards, I believe that we are still there with these priorities. We will go one by one rather quickly. The next slide will be priority 1, and that's the key now about the political will and financial sustainability for services. And it's starting with the political priorities on the European level, where we don't have the harm reduction and drug policy priority in funding, and that's somewhere in between DGs and DG home, and unfortunately there are no priority, and it goes to the countries. The next priority is about the community-driven harm reduction services tailored to diverse needs of people who use drugs, and we are speaking here about the intersecting identities of people who use drugs, and that's LGBT, that's women, that's youth, and people who are using very different, that's migrants, that's Roma people, and they all need the very tailored harm reduction and services. And the next priority is about access to specific services for people who use drugs, and we see here the list of priorities, and that's something we need to develop the models, how to connect all the services to be accessible, even if the costs are very limited. So we are not luxury enough to have all the complex in one-stop shop, but to connect it, and that's where our lighthouses are very important to show that it's possible. And the next, that's about health and social care for people with drugs, and that's again about the mental health, sexual reproductive health, general access to general health services, and social care. We see examples of the services when the harm reduction could be connected with the mental health and connected with the addressing homelessness and even the residential projects. It exists in European countries, and that's actually, it's not something miracle. It's possible and doable. the only part coming back to the first priority, political. And we did practical, that's the strategy you've seen already, and described, and the next slide will show you that we found resources to support 6 organizations in different sub-regions for the practical advocacy during last and this year, and we are very happy to have our partners in the countries, even though resources are very small, but I need to say that for majority of European countries now, even 5,000 euros for advocacy and for supporting community, it's big, huge resources. Unfortunately, we're in a situation where organizations lacking resources for services and for advocacy, it's like sound as unreal, and that's why we are very cherished the initiatives which listed here and which we could support.
Good. We can do it now. So I give the floor now to Lydia, a colleague from the European Advocacy for Drugs, who actually they were very involved in everything. Like when we did the kind of this regional focus groups, they were always present like there, and we always had them with us, and it's also very good that we work in parallel. Sometimes people say, community-based and community-led are different organizations, you know. In a way, yes, but there is such a good cooperation between us, and like also what was already heard here, that we were working very well together when we were designing the project and now in implementation. That's a good example that our colleagues from the communities are always with us and are really participating in it. Ligia, please.
Thank you, Milutin. In fact, I believe that your input feels, and people of your input feel very integrated in this Boost project. So it's not the first time that we are collaborating, and indeed I believe that we are progressing and in acknowledging each other skills and making it worst for a common goal, of course. So there are many ways to collaborate, more integrated or less integrated, and in time also the dynamic can span. If community-led are answers that are there first, they will be acknowledged by community-based organizations, and community-based organizations will also fuel and nurture the community-led organizations so that they can do their work in each context. So I'm going to focus in my presentation to you, which is based this kind of a narrative, also in time, which I built to protect me a bit from the irrationality, from the instability, from all the news. So I'm kind of making some blind eye to that, so that I can start, go to the bureau, and then to the end without being more disturbed. I'm going to propose to you some initial assumptions. One of them is that drug use spans across all demographics, so everywhere, everyone, in the sense that it's all age, all geographies, all races, all ethnicities, all genders, and every profession. So there are no barriers to this. It exists across all society, let's say. We also know that punitive drug laws disproportionately harm marginalized people. So when we talk about harm reduction, we know that it doesn't arrive to everyone who needs it. Certain populations continue to be left behind and face barriers when accessing healthcare services, including due to stigma and discrimination. Also, peer outreach workers and often active drug users are especially effective in reaching hidden drug scenes and engaging new clients who are not using harm reduction services. To leave no one behind, we need to employ active drug users and those in treatment that can significantly strengthen harm reduction efforts. Effective peer engagement is indeed the cornerstone of a dynamic and responsive and updated harm reduction service, but often the peer engagement gets boxed into rigid roles that people cannot perform. So, when we prioritize those at greatest risk of infection with HIV, of lack of treatment, if we prioritize those, we will be, for peer roles and for leadership, we see the service delivery sparkling and going further. But you need to have this, to prioritize also these peer roles. And it should be underlined because, of course, we tend to hire people that are more stable, more able, more capable, but we forget what we are forgetting, that we want to reach people that we haven't reached yet, that need to be reached. So we need to prioritize those. So, since the 80s, we have impactful and documented results. First, with the needle and syringe programs led by people who use drugs. In 2006, we have the Vancouver Declaration, we dedicated to explain why the world needs an international network of activists who use drugs. Community-led organizations have been documenting case studies and sharing examples of good practice. A big part of Boost is dedicated to this. These examples are notable for their flexibility and for their adaptability. It's towards what is happening in the local place, in the places. It's not something in general. And this is the case. Maybe we can start showing that slide of mine. This is the case, this collection of case studies, the documentation of case studies and sharing with examples. It is the case for the peer-to-peer naloxone program and peer-to-peer distribution of naloxone, the technical guide that has been developed, and within Boost, documenting community-led approaches to HCV testing, treatment, and care. So, in every situation mentioned, peer work is evidenced as cost-effective. This will be something important to understand when we are talking about funding. We also have, I may add, after the experiences and the leading Vancouver Declaration in 2006, we also had the NGAS in 2016 that launched some quantitative goals for the community involvement, and also the Global AIDS Strategy 2001-2006 that went further. Even in those goals, it is a very bold strategy, is very updated strategy, and they already mentioned in this idea of, but what have we progressed in this idea of counting with peers, having the communities leading and delivering the harm reduction services. So the strategy already says that the communities are crucial in the HIV response. The capacity of community-led, so the communities are crucial, but the capacity of community-led responses, key populations and youth to contribute fully towards ending AIDS by 2030 is undermined by acute funding shortages, shrinking civic space in many countries, and a lack of full engagement and integration of national responses. So where are we? Where are we with the goals that were proposed by the Global AIDS strategy? This is a very important question. So we need to have the evaluation and the mechanisms of evaluation so that we can know where we are. This is something that we are very turned into. In a recent evaluation in Europe, within the essential harm reduction services, the report on policy implementation for people who use drugs. It's published in 2024. What has it found in Europe? That people with lived experience are more involved in harm reduction services than people with living experience. This is where we are. And that in both groups, most people are involved as volunteers rather than paid staff. The involvement is higher in service co-design and delivery, and there is less engagement in the service evaluation and in the governance. Also, within Boost, we made some evaluation with a total of 17 peer workers that is going also to confirm these results. In fact, in Europe, this evaluation was with 17 peer workers, 2 were working full-time, 7 part-time, and all the others were volunteers. So after for the global AIDS response strategy, there was global consultation, not only Europe, a global consultation about scaling up, looking for recommendations with community for scaling up and reporting on community-led AIDS responses. I selected some of the recommendations to bring to you, some updated and sometimes already repeated, I think already repeated several times, but I will have to repeat them again as we still find ourselves, we still find that we are not progressing enough in this area. So, okay. So one of the things that the global consultation of community said is it is important to measure the progress against these targets. This is an effort that is being done in the last years, and it must be sustained. It's necessary to adopt and implement laws and policies that enable the sustainable financing of people-centered and integrated community responses, including through social contracting and other public funding mechanisms, especially core funding. And this funding is, core funding is emphasized as one of the most crucial for supporting community-led organizations in order to guarantee their strength and sustainability. Leaving no one behind means that people with disabilities, young people, and rural populations are included, and the indicators should measure their contributions to the response. Also, it is recommended that a clear code of conduct should be developed involving staff and its creation to ensure mutual understanding. Policies should focus on fitness to work rather than penalizing staff for drug use, aligning with harm reduction principles. It's necessary to establish equitable payment standards for peer engagement to ensure effective health service delivery and social justice. And one of the most repeated, prefer cash payments unless otherwise is requested. Avoid gift cards as they can be patronizing, and cover other costs directly as transportation, accommodation, meals, and childcare. True engagement means preparation, fairness, clear expectations, and just compensation. Thank you. I leave you the tools that Euronput has been developing on the perspective of peer-to-peer harm reduction. Thank you for your attention.
Thank you, Maria. Thank you very much. I think it's always very useful to be inside from the community to correct whatever we think is useful for them. And it doesn't go without them. So I give the floor to Marius, who is our board member for some time already. But Marius at the moment is also working in the city administration of Athens, so maybe he has kind of a several hats. So I think his presentation will be useful because it's both-sided in a way, and it will be mainly on decriminalization and stigma of people who use it.
Okay. First of all, I'm Marius James, I'm board member of the Drug Policy Network, advisory board member also of the Correlation Network, and currently working for the city of Athens, which is a unique experience for me as a peer. I would like to thank the previous speakers because they covered a lot of space. I have a very short speech. It's like about 3 hours. You should be really focused on what I would say. Okay, now let's proceed.
You can do it.
You know, for the last 15 years, in what is going on in my country, in Greece, I could write literally a book. You know, and now we are facing, like we are witnessing, profound changes in the world at this time. And you know, the social, historical, economic, cultural, and political context is not separate from drug policies. On the contrary. And we must stand united and resist in what is coming. Because what is coming, it's really a conservative wave of penalization and criminalization of the most vulnerable existence in our planet. I would like to tell you that as someone who has worked closely with people who use drugs, and also as a person who lived the experience, I have witnessed firsthand the profound impact of the criminalization that has on people's lives and on public health. In fact, my personal journey includes being part of an HIV outbreak among injecting drug users in the center of Athens between 2011-2013. So I know firsthand what it means to be persecuted, to play hide and seek with the police on the streets, and all while struggling to survive, just to be treated as a human being. Criminalizing drug use creates significant barriers for people seeking health services, including mental health services. The fear of legal repercussions discourages individuals for accessing life-saving harm reduction and healthcare services, and moreover, the stigma associated with drug use, reinforced by punitive policies, isolates people, making reintegration and support really, really difficult. The most vulnerable group where I come from is the migrants and the refugees who use drugs. I participated in the semi-DU research on migrants and refugees who use drugs, and the findings were shocking. Not that I didn't already know or expect them. I can't even begin to imagine what it's like that for your very existence to be considered illegal, forcing you in a constant state of being hunted. I have accompanied people to HIV clinics as a part of a peer-led harm reduction linkage to care, and we had to change our public transport route just to avoid encountering the police. The evidence is clear. Criminalization does not reduce drug use. Instead, it exacerbates public health crisis by pushing individuals into riskier environments, increasing the spread of infectious diseases, and perpetuating cycles of marginalization. Harm reduction strategies, on the other hand, have been proven to be effective in mitigating these harms and saving lives. At the last European Harm Reduction Conference in Warsaw, high-ranking UN officials spoke openly about the need to move towards the regulation of substances. One of the most impactful discussions took place during the mayors panel, where mayors, city council members, national parliamentarians, members of the Global Commission of Drug Policy, and senior UN officials led by the mayor of Amsterdam engaged in evidence-based discussion on drug policies free from ideological biases and the moral panic of the past. The mayor of Amsterdam emphasized the need for drug regulation as a means to combat crime and to protect public health. In the same spirit, Volker Turk, the UN High Commissioner for Human Rights, made a powerful statement about the global war on drugs. He said the war on drugs has failed completely and utterly. He urged leaders and international stakeholders to radically rethink global drug policy, highlighting how this decades long approach have destroyed communities. Similarly, Zaved Mahmoud, the UN Special Advisor on Drugs and Human Rights, echoes this sentiment. At this point, I want to remind everyone that the city of Athens is actively participating in the European City Initiative on Drug Policy, an initiative led by Correlation Network. This initiative fosters collaboration between local governments, field professionals, people who use drugs, and their organization to drive positive changes in drug personnel. I personally worked very hard to ensure that Athens became part of this project. Our city presents one of the most severe challenges in Europe regarding open drug scenes, social distress, and most critically, extreme high mortality rates for drug overdoses and HCV prevalence among people who use drugs. But for the first time, the city of Athens has developed also an action plan on drugs that includes specialized training for frontline workers and street outreach teams in naloxone distribution, harm reduction approaches, and the prevention of infectious diseases. And closing, I go back to the title of this session. Advocacy in action is our tangible presence in hostile environments where even our very humanity, our existence, is sometimes called into question. It is the ability to translate our lived experience from the streets into policy proposals using the right analytical tools, as well as to amplify the voices of those who over the years have entrusted us with their pain, with their joy, with their tears, and with the secrets. I'm talking about our peers. Advocacy in action is not just a concept, it's the active presence of peers in decision-making processes, the fight for human rights, inclusion, intersectionality, equitable access to public health, and respect for each individual unique existence is ongoing and non-negotiable. Thank you.
Thank you. For us in Southeast Europe is kind of a lighthouse about how things can change. I remember times of COVID when Before COVID, there were no street work by community. And then during COVID, the city of Athens understood that they have to change something. And that's when they went out of the street. And the result of that, which was kind of fostered or forced by the situation, is the current situation which Mario said. So small steps, and I think we can come to this, and I guess that most of us will, or all of us will agree that that's the way how we can improve and have good results. We had one of the organizations which supported this event is Unite, the Parliamentarians Network for Global Health. They're not in Vienna, they are not present here, but we have a presentation, a message which was sent by Honorable Halldóra Mogensen, a recent member of Alþingi, which is the national parliament of Iceland. I think that the oldest parliament with people involved, it's like more than 1,000 years of existence. So I will let her speech, and it's unfortunately the sound is only from this computer, so I hope you will be able to hear it. So, okay.
Dear colleagues, I'm honored to have the opportunity to address you today at this critical discussion on advancing comprehensive health and harm reduction services. As a former parliamentarian, I have seen firsthand the pivotal role that MPs play in shaping policies that safeguard public health and uphold human dignity. One of the key issues we must continue to address is the necessity of shifting from criminalizing drug use and punishing drug users to understanding and responding to the deeper causes of addiction through a compassionate and health and well-being centered approach. Punitive drug policy, it exacerbates harm. It pushes vulnerable populations further into the shadows where they're deprived of the essential healthcare services they need. We have to recognize that substance abuse is not a moral failing. It's a complex health issue and social issue that demands a compassionate, human rights and evidence-based response. Stigma and discrimination are today still major barriers all over the world, preventing individuals from accessing life-saving interventions. Criminalization fosters fear. It discourages engagement with healthcare providers and undermines public health efforts. Policymakers, they have the power to dismantle these legal and societal obstacles that marginalize people who use drugs, and to create laws that ensure that people are treated with dignity and that they receive proper care. An integral part of this approach lies in expanding healthcare services that are run by and for the communities they serve. These programs, they work because they understand people's needs and they build trust. They provide medical help, mental health support, overdose prevention, and social services. And these programs, they have to be strengthened. They have to be supported and funded adequately. And this brings me to a crucial point, funding. Because despite overwhelming evidence of the cost-effectiveness and life-saving impact of harm reduction services, many programs operate with insufficient resources or face constant financial uncertainty. Parliamentarians have the platform. They have the ability to advocate for sustainable funding mechanisms that ensure the continuity and expansion of these essential services. And investing in harm reduction is not just a moral imperative. It's a pragmatic public health strategy that saves lives and reduces long-term societal costs. We have to understand that effective policy change, it doesn't happen in isolation. It requires genuine engagement between policymakers and the communities most affected. I encourage all parliamentarians to listen to the voices of users and the people living in vulnerable communities, to learn from their experiences and to involve them in decision-making processes. The success of any harm reduction strategy hinges on the strength of collaboration between policymakers, harm reduction experts, users, and their communities. Coordinated advocacy efforts can drive legislative reforms, break down barriers, and foster a more just and inclusive society. So today, I urge all MPs to commit to this cause, not only through words, but through concrete actions. Let us work together to ensure that harm reduction is fully integrated into our public health systems, that no one is left behind due to stigma or discrimination, and that we build policies rooted in evidence, compassion, and human rights. Thank you.
I hope you were able to hear, and it's good to have this kind of nice message from a parliamentarian inviting other parliamentarians. And as we heard here, the political will is maybe the key point that we want to use. Gana, you want to add something?
Yeah, I wanted to say that, of course, you will ask what next. You have a strategy, what you are doing. And actually, the Honorable Member of Parliament is like highlighted what we think we are doing. And last year, a lot of organizations, including Correlation and Advocacy and other organizations, we initiated the manifesto, and like-minded candidates to European Parliament signed it, and a lot of civil society supported this manifesto for humane drug policy. And it is on the Correlation webpage, and you could find all our logos of all supporting civil society organizations and like-minded organizations. What we are now thinking and starting doing, the Euro Parliament is already in place, and some of our supporters are in the Euro Parliament. So what we are... Yes, and they already settled. They have a team. So right now we have the important task to do is to coordinate their effort. Who are sitting in the committees on justice, on security, on health, to be united around the drug policy reform. If you have any ideas or contacts on the level of Euro Parliament, because the key agenda will be the specific funding for drug policy and harm reduction on European level, because if not, we will all could disappear. And also the very important ask is to contribute, and for all of us to contribute to the European drug strategy with all these messages we have in our strategy, and to have real balanced European drug strategy and action plan on not only on supply and demand reduction, but also on harm reduction. And that's important. Three pillars we are advocating for. And the important also the window of opportunities for Ukraine, Moldova, hopefully Georgia, and the Southeast Europe countries on accession, because that's also a message which Europe together could send to the accession countries to reform the justice system, to ensure human rights, to ensure access to health services for people with drugs. So that's on a nutshell, just three key priority. We will try to emphasize and to work with the MEPs on the Euro Parliament level, and hopefully all other initiatives we have in the room and we have around, we could coordinate for joint effort, because even resources to go to Brussels for the meeting, it's very limited. So we need to be very up to the point in this advocacy together with DG NIR, DG Home, DG Santé to address the issues. So that's our plan.
Thanks. Yeah, just to be more specific, we were informed in the European Civil Society Forum on Drugs that there will be evaluation of the current strategy, which expires this year by summer. And then only after that evaluation, they will design a new European drug strategy. So second part of the year will be work on the new European drug strategy, and that's where we should be active in trying to have there as much as possible things we do here. And also Ghana as chair of the forum, and I am also member of the core group. Two of us coming from Eastern Europe, candidate countries, we are pushing always on these accession processes, trying to not have them as it is now. 99% only about law enforcement, and only a couple of mentions in some sentences about health, and zero about human rights. We would like to change it. So we have some more time now. Formally it's 5 minutes, but the only thing with the change of the dynamics of the CND is that in between the side events there is half an hour at least, so we can even stay longer, those who don't have other opportunities. So please, if you want to contribute, just it's open We have here people who are working, like as we heard, Vila Marini. We also have Juventus from Montenegro, who was supposed to be lighthouse, but at that time Montenegro was not able to join Europe for health program. If you want, we can give you more information about how it works on the practical level with lighthouses, but maybe somebody else would like to ask something or to add something, please. Okay, Victor or...
Just a comment. Thank you for this item, because it's really encouraging to see that you are united. I mean, the associations of the community-led and community-based and peer-led and so on organizations in Europe. It's very important because, I mean, we are living in critical times, I would say, not only with regard to the budget constraints probably coming or present on different levels, but also policy changes. On the other hand, policy changes are also encouraging with regard to the new European drug strategy. It will be interesting to see the changes in the strategic development of the strategic vision of Europe with regard to the recent developments at the national levels. There are many countries, even between the present and the forthcoming strategy, made a substantial progress towards decriminalization, regulation of different substances, including Czech Republic, I should say. So, I mean, this is also opportunity, I would say, for the topics we are discussing. And the last practical thing, this parliamentarians network, it's very, I mean, interesting. It could be useful also at a national level. So maybe I'll come back to you during the break to give me some contacts to pass it through to negotiate the involvement of the Czech parliamentarians into the network. Good. Because, yeah, it's important.
Yes. Okay, yes, please.
Sorry, I just heard this great discussion and your connections and all this input for the rules to change in Parliament and so on. I'm absolutely on your side.
Please, for people who don't know you,
My name is Gustav Fasching. I'm a representative of the Elternkreis Wien. We're a self-supportive help group for parents with addicted children, and they meet each other since 30 years. We are having this
in Vienna.
Here in Vienna, yeah. And I just know maybe it's a good best practice example I was missing out for. In Austria we have this things like, I think there's a special department for addiction and drug consumption department, and they have a special budget. And so people, they are dealing with a consumption problem. They get a free therapy with a multi-professional team, with a medicine doctor, psychiatrist, social care worker, clinical psychologist, and a psychotherapist for a period for 1 or over 2-3 years maybe if it's needed. So I'm sure that I was thinking till now that's normal for every country, or should be for each country, and I think it's maybe a good thing to work with the states together to have a good example for how to make it or how to do that in its own country. But everybody has a chance to implement this. Should be implemented. Thank you.
Yes.
I think I would like to respond to what Victor was saying about the new drug strategy and change in Europe. I mean, for sure we are very concerned with the current EU drug strategy, which could be definitely improved from our perspective. The only hope is that it remains like that, and the so-called balance between drug supply and drug demand and harm reduction remains. But our biggest concern is actually that the unbalanced implementation of the EU drug strategy, because you can have a wonderful strategy and action plan, but if no one is being held accountable for implementing it, because currently the EU is only supporting drug supply reduction, and this is the point. And DG Home is referring to DG Sante for health, and DG Sante is not responding, and also the social fund, European Social Fund, is not being responsible. So I think this is such focusing. And going back to what, I'm happy that you are here because I think you are an important partner in advocacy. Because, politicians won't listen easily to us, but to listen to parents, I think this is a very good and strong group. Yeah.
Thank you.
Ivana from Juventus, Montenegro.
Ivana from Juventus, from Montenegro. So thank you for beautiful presentations. An important project. I have one comment. It's maybe just thinking aloud that there is one opportunity and threat in the same time regarding the European Union, and it seems that European Union is shifting priorities toward the economy and security, which, especially for the accession countries, focusing only on, primarily on the economical reform. So we also need to shift our advocacy in that sense and to be also very, very, very sensitive in that regard, because it could, how to frame our advocacy, because it seems so. Economical reform, not anymore that much values in human rights, and on the other hand, we are seeing that our partners, that were our traditional partners like Netherlands, UK, also Scandinavian countries are cutting the funds, but not only cutting the funds, but also cutting their presence and cutting their support in advocacy, which was in some senses much very, very important and even more important than funding. And distributing those parts of the budgets to the security and military funds, so, and also economy. So we need to be aware of it and to reframe our advocacy efforts, but also to be afraid of potential framing against our core values.
Yeah, just note to that, we are thinking about that in Czech Republic as well, on different levels and groups, I would say, and we are more and more convinced that we should reframe, or maybe put in the framework of our definition of the policy reforms, also security and safety, yes, and also the budget, money, simply the prohibition and the penal prohibition and enforcement cost a lot and increase the violence and decrease the safety and security, right? So it works to think about how to link it together and simply to put into the list of arguments also that one.
Yeah, on the
not
meeting
only health, human rights, but also safety.
On the Civil Society Forum, we had a discussion about the violence related to drugs, and that's kind of key issue at the moment in Europe. But then most of the answers is to increase police presence, equipment, training, and our response was from the civil society, resilience of communities, invest into communities, and that will decrease the crime. So it's not just one direction.
The answer is decriminalization and regulation. Yes.
Good, thanks a lot. Yes, you want to? Yes.
Yes, I would also like to add something. I'm the new executive secretary of the Pompidou Group, and I'm happy to support what you are doing. As you know, the Pompidou Group is part of the Council of Europe, and we are lucky to have an approach which is based on conservative values, and I wanted to draw your attention to the recently adopted policy paper bringing human rights to the heart of drug and addiction policies. It has been quite challenging to adopt such a policy paper in the current context, which is not so favorable, even if there are some exceptions like the Czech Republic, but the wind is not blowing in the right direction, I would say. It took something like 10 or 12 hours of negotiations to finally have the policy paper. And the good news is that there is a very strong message in this policy paper about harm reduction, and I can maybe read it out.
Evidence-based risk and harm reduction is grounded in justice, public health and human rights. It focuses on positive change and on working with people without judgment, coercion and discrimination, or requiring that they stop using drugs as a precondition of support. It must be implemented in order to prevent correlated diseases or greater harm, such as overdose, and put people with addiction in contact with healthcare services. Harm reduction improves not only the health of people who use drugs and those with substance use disorder or addictive behaviors, but also that of their families and relatives, their immediate environment and society as a whole, and it is based on a strong commitment on human rights. This is a powerful message and you can use it because the paper has been officially adopted by 41 member states of the Commonwealth.
So it's not only European Union, it's also
It's
wider
across
Europe.
of Europe. It's wider Europe.
Yeah.
Yes.
Thank you very much and enjoy the rest of the event.